recorded. I'm going to I was going to share the screen. There we go, our anti-infectives. Sorry to be less than prepared. I like to get stuff ready before class started, but like I said, I got on the phone with Miss Taylor and started running out of time. I'm going to make this a little bigger. So our anti-infectives. So before we get started on our anti-infectives, did anybody have any questions about what we had started? I'll kind of go through the slides and do very brief. So our anti-infectives, remember those are the classification of medication that is going to be given is based on what type of microorganism it is. And if need be, to do a culture to find out what that organism is. Ooh. And I got lots of chats. Asking for the course outline. It is up and posted. Also, what I'm doing is, and I'll show you in a little bit because I don't go back and forth, is listing the grouping of those LPN collections, those skills to look at, as well as the shadow health. I was trying, one of the things I wanted to do that I have not yet had the opportunity or have done is, see, here I go trying to multitask. Where did? Sorry, Tori, trying to let Tori in. There we go. Again, that silly waiting room that I thought I got rid of, so I apologize. Giving those shadow health, the Evolve LPN collection, putting those in chunks to kind of match the skills as we go along, as well as the shadow health. What I wanted to do, I wanted to look at Ms. Taylor's schedule to try to avoid any overlap, but I'll be honest, I didn't get to that. So as we go through, if we find that we've got overlap or you've got a lot of things going on in both classes at the same time, we can flex those. But the course outline is up with the chapters and quizzes and exams, but these very specific, like I said, the Evolve and Shadow Health, those dates haven't been put up yet. I can show you where I started. Grouped them. But our anti-infective, so again, they may have to do a culture to find out what microorganism it is, and depending on the microorganism depends on the drug. So we talked about bacteria, antibiotics are for bacteria and bacteria only. Antivirals are for viruses. Antifungals are for fungal infections. We won't give an antifungal for a bacterial infection. We won't give an antibiotic for a fungal infection. Very specific. So remember that culture, that is where the specimen is swabbed, whether it's a wound, a throat, a blood sample. That culture is then sent to microbiology. It is allowed to grow and develop 24 to 48 hours. 48 hours is the minimum to get a result. They can then identify what type of microorganism it is. Once identified the type of microorganism, particularly if it is a bacteria, they can then do its sensitivity. And that sensitivity is putting little discs of medication, in the case of bacteria and antibiotic, putting those discs of medication on that growth to see which antibiotic kills the bacteria. So that's the sensitivity. So that could add the additional 24 hours onto that test. So the culture and sensitivity, 48 to 72 hours, 48 for the culture and up to 24 for that sensitivity. Also remember when we're doing a culture and sensitivity, if that is an order that a provider has made or done, then we want to make sure that we get that specimen taken or that blood drawn before we start the anti-infective, because we don't want to interfere with those results. The multi-drug resistant pathogens, we talked about those. MRSA is one that I think everybody is familiar with. Methicillin resistant Staphylococcus aureus, VRE, vancomycin resistant, KPC, Klebsiella, but these are microorganisms and bacteria that have become resistant to antibiotics because over time they have developed their own set of armor, their own method to attack. So to combat or treat these conditions, we have to use very powerful multi-combinations of antibiotics. Talk about the patient education, finish anti-infective therapy. If it says take it for 10 days, take it for 10 days. Just because you feel better after 3 doesn't mean that infection is gone. So we need to make sure patients continue with that anti-infective therapy. And then hand washing. And again, we talked about, we think some of these measures are very, very well versed, very well known, and much more highly practiced these days than I think previously. When we talked about our antibacterial drugs, the antibiotics, again, those are to treat bacterial infections, and then all the different classifications of those antibiotics. The aminoglycosides, penicillins, cephalosporins, tetracyclines, macrolides, quinolones, and then the miscellaneous. So we did go through and talk about the aminoglycosides and the penicillins on Thursday. So we'll kind of review those, but some, again, nursing considerations, no matter what type of antibiotic it is, we want to assess for drug allergies. Remember, antibiotics has our highest rate of adverse or allergic reactions than any other classification of medications. So if we are in an outpatient setting and we are giving an antibiotic injection, we want that patient to stay 20 to 30 minutes to make sure they don't have a reaction. They may say, I've never had one before. Well, no, you haven't. It's repeated exposure that causes that allergic reaction. And remember, an allergic reaction is an immune response. So we'll have, start with itching, hives, a rash, hives, then going up into the vasoconstriction and the bronchoconstriction and airway. So an allergy is an immune response. An upset stomach is an adverse effect or a side effect, not an immune response. So we want to make sure that we truly find out what their response was when they say an allergy. The other is make sure that they don't have a condition or a medication that is the contraindication to the antibiotic or the anti-infective therapy. Look for those drug interactions, and again, we always do that culture and sensitivity before we start any anti-infective therapy. So with our other nursing considerations, take those antibiotics as prescribed, and as long as they're prescribed, they are better taken with water. So good thing, or I should say they're better absorbed if taken with water. So we promote that glass of water with the antibiotics. And then again, with our antibiotics, we want to watch for super infections. And those super infections are infections that are a consequence of taking that antibiotic or that anti-infective. So again, I mentioned last week, one of the most common are females that take antibiotics end up with a vaginal yeast infection. Again, it's because that normal flora, that bacteria that normally keeps that yeast at a certain level, the antibiotic kills the good yeast or the good bacteria, the good flora as well. So it allows that yeast to overgrow. So super infections. Also, Each of these classes of antibiotics have very specific adverse effects and interactions, and those are the ones I will point you to. I'll say, you know, make sure you remember this, make sure that you really hone on this piece. But again, for our adverse effects, any of our antibiotics, excuse me, are going to be nausea, vomiting, and diarrhea. Just put that down. Nausea, vomiting, and diarrhea is an adverse effect of any of our antibacterials or antibiotics. And again, that water reminder. Oh, let's see. So we had done this classroom response question previously. Again, it's when that admission assessment, they say they're allergic to sulfa drugs. What do we do next? We do get more information about that allergic reaction, because we want to ensure it truly is an allergic reaction. And why? Well, one, we want to make sure that we don't give them medications that they are allergic to, but if they're experiencing a side effect rather than an allergic reaction, and this medication is the best medication to treat their condition, then we want to be able to give that to them. So we did talk about our aminoglycosides. Excuse me, our aminoglycosides. Now, when we talked about the pharmacodynamics, how does the drug work on the body? What is the action on the body? And I said, for most of these, I don't expect you or need you to know that some of the more intricate or specifics. So what do antibiotics do? Antibiotics control bacteria, treat bacterial infections. Now, what I mean by you don't need to get into the specific, an aminoglycoside is a bactericidal antibiotic. It means it kills the bacteria. Some prevent growth, some kill the bacteria. This one kills it. So I don't care if you know that it kills it, know that it treats bacterial infections. So with our aminoglycosides, you can see the medications that are listed in there. The ones we're probably most familiar with: gentamicin, neomycin, tobramycin. Vancomycin is in there, not because it's an aminoglycoside, but because it acts just like an aminoglycoside. But notice the suffix on there, the mycin. So that mycin is a suffix that tunes us into it. It's an aminoglycoside. Now, these are really heavy duty antibiotics. They're usually given injectable, IV or IM, except for that neomycin for intestinal surgery. They're often given in combination for that synergistic effect. But the one thing, remember, with our aminoglycosides, and this is one of those things I said, you know, tune into, is particularly the ototoxicity. So toxic to the ears can cause hearing damage to the auditory nerve and cause hearing loss. And then also nephrotoxicity, so kidney can be toxic to the kidneys. So this is one of those things that aminoglycosides are very known for. So I want you to tune into that, pay attention to that, because that is going to be a common test question maybe, and a very common NCLEX question is treating or recognizing the ototoxicity. And how does that usually start? They'll start complaining of ringing in the ears. If they're complaining of ringing in the ears, we need to stop that aminoglycoside and let the provider know. The aminoglycoside is one of those that we want to make sure that blood level is at that therapeutic level. So do that peak and trough. And remember, if we're doing it IV, that peak where we want to find out the maximum, that highest level of drug in the body, we're going to administer it and IV, and 30 minutes after it's completed, we're going to get that peak. If it's IM, intramuscular injection, we're going to administer it, and 1 hour later, we're going to check that peak. So that's going to give us that high level. The trough is, what is that low level? And when is that lowest level going to be? It's going to be before we give that next dose. So that's when we would draw the trough. And what we want to make sure is between the peak and trough that is at a therapeutic level, but not toxic, not a toxic level. So the aminoglycosides. The next group we talked about were the penicillins. And again, with all of these different penicillin groups, you don't need to know the different penicillin groups. You need to know which one are the penicillins. The nice thing is they all end in "cillin." So those penicillins. You might recognize some of those names, the amoxicillin, ampicillin, some of you might oxacillin, but they're the penicillin groups. Now, the penicillin groups are still one of the most widely prescribed in penicillin because it's a broad spectrum, meaning it hits all different types of bacteria. They're still widely prescribed and widely used. Look at how many dose forms that they're available in. They're PO, so we've got liquid, we've got tablets, IM, so we can give an intramuscular injection, IV, so it can be an IV infusion. So lots of different dosage forms. And again, with that antibiotic, take that on an empty stomach to help with that absorption. Now with our penicillins, so this is where that allergy information again becomes very important. So maybe they didn't say they were allergic to penicillin, but they said they were allergic to a cephalosporin. So because there is a cross allergy between penicillins and cephalosporins, if they complain of, or if they have allergic reaction or allergy symptoms to one class of drugs, then we want to not give them the other class either. So cephalosporins and penicillins, that cross allergy. And remember, with these IM injections and penicillin intramuscular, we're going to give it in the ventrogluteal. So in the hip, we want it in, or in the vastus lateralis. Antibiotics are thick and they hurt when they go in. So we want it in a big muscle, help absorb that. So with our penicillin, again, remember those taking penicillins, wait 30 minutes after administration. If it's in an outpatient setting, we want to watch for those possible allergic reaction. And then the adverse effects, in addition to nausea, vomiting, and diarrhea, is the anaphylaxis. And so that is that full-blown allergic reaction that we don't want to see. Rashes, pruritus, so the itching, serum sickness, super infections. And remember, penicillin, there are a lot of interactions. And look at this. So NSAIDs. NSAIDs are your ibuprofen, Aleve, naproxen. How many people take something like ibuprofen for a fever when they're taking penicillin? So we just need to be aware of how these interactions work. The other, look at this, oral contraceptives. So I mentioned this, it says oral, not hormonal. So these can interfere with birth control pills. So if we have a female patient on birth control pills, we may want to say, hey, you might want to use a backup form of birth control. Now, while oral contraceptives are not listed with all antibiotics and as interfering, I think it's safe to say that it's always good to advise our female patients on oral contraceptives when they're taking any antibiotic, because they can be so hit and miss. Just if you're on antibiotics, you need to use another form of birth control. Okay, so that we kind of did our quick review, you know, as quick as I can, because quick is not always in my name when I'm talking anyway. So our aminoglycosides and our penicillins. So two classes within our antibacterials or anti-infectives. So the next class of antibiotic or antibacterial are the cephalosporins. Cephalosporins. So again, broad spectrum bactericidal, that part's informational. You don't need to know that. But so they're very much related to penicillin. So remember, cephalosporins and penicillins, there can be that cross allergy, because even though they aren't in the same drug class, at the very structural level and how their pharmacodynamics are very similar. That's why we don't want to give those if they do have that allergy. says divided into groups according to their microbial activity. Okay, so look at this. We have got 6 generations of cephalosporins. Do you need to know 6 generations? No, you do not need to know. What you need to just kind of be familiar with are what are cephalosporins. For the most part, cephalosporins start with Ceph, C-E-F. So cephatoxin, cephatan, Cephalosporin, so Ceph, so that has that prefix. The other medications that we've talked about, we've been looking at the suffix, the psyllin with penicillin, the mycin with the aminoglycosides. With our cephalosporins, it's going to be the prefix, the start. So Ceph, C-E-F. But you do not need to know which generation is which. What do we need to know about our cephalosporins? So our nursing considerations. So again, assess for that penicillin allergy and vice versa. I think I've said that a couple of times, so that sounds like it could possibly be a quiz or a test question at some point. Hint, hint. So we said, water helps to absorb our antibiotics, but with the cephalosporin, they can cause a lot of tummy upset. So they can take them with food, but just know that that absorption is going to be delayed. If it's trying to break down and digest food at the same time as the medication, it could be a little bit of delay in the absorption of that antibiotic. Now, because cephalosporins can cause those super infections, the vaginal yeast infection, it can cause some GI distress and GI super infections, to eat yogurt or drink buttermilk to restore normal flora. Now, I am not a buttermilk drinker, but yogurt and buttermilk do help to restore that flora that the antibiotic has wiped away and has allowed kind of a super infection or the beginnings of a super infection to start. So if we eat yogurt or drink buttermilk, then it will help decrease that or maybe even prevent. So with our antibiotics, and again, so we've got nausea, vomiting, diarrhea. I should have put anaphylaxis as another adverse effect because of the high chance of allergies with our antibiotics. They also, again, the rashes, pruritus, so itching, so it can cause some bleeding issues. So, bleeding gums, so want patients to be aware of that, and then also the super infections. So right now, as far as adverse effects, the only one group that is standing out at this point are the first one, the aminoglycosides with the ototoxicity and the renal toxicity. So again, keep track of those. But we're seeing very consistent adverse effects with our antibiotic groups, even though there are tons of them here. So now we have our tetracyclines. So what are tetracyclines? Well, look at this. They have a common suffix. They have cycline. So that makes it nice. Now this is bacteriostatic, so they don't go in and kill bacteria. They just prevent more bacteria from growing. They are available in oral, PO formations, as well as IV. And so we've got our doxycycline, tetracycline, so all of our cyclines. Now, here's another thing to put a little star by and to remember for the tetracyclines. We want to avoid milk products, iron preparations, antacids, so that's like your Tums, your Mylanta, and other dairy it says because of chelation and drug binding that occurs. So what that means, basically, the milk products, iron, antacid, and other dairy products, when they talk about the chelation, it binds with the chemicals or with the tetracycline. And if a woman is pregnant, it will cause deformities in the fetus. It also, if for children or adults, it can cause real severe discoloration of the teeth. It's like a gray tint to the teeth. But tetracyclines avoid dairy products, and antacids are the two big ones. And again, take that with water. Definitely don't want to have them take that with milk or with other dairy products. So where we encourage dairy products with our cephalosporin, the buttermilk and the yogurt, to help replenish that natural flora, with tetracyclines, we're saying no dairy products, no buttermilk, stay away from that stuff, no antacids, because of the binding, the chelation and binding. Now, other nursing considerations for our tetracyclines, those are, they do cause photosensitivity. So we want to warn our patients not only to avoid the dairy products and the antacids because of skeletal fetal deformities, as well as the graying or the discoloration of the teeth, but also because it can make someone hypersensitive, photosensitive. So if they're out in the sun, they may have a sunburn where they may not be prone to burning before. So we want them to avoid the sunlight and tanning beds. Now, we should be telling them to avoid that for other health reasons anyway, but particularly with the tetracyclines, it causes photosensitivity. What are tetracyclines used for? So not only are they used for infections or just general bacterial infections, they're very specifically used to treat acne. It's one of the antibiotics that is thought to help clear up the acne, which is not a specific acne medication like Accutane. It's also very specific for chlamydia, which is a sexually transmitted infection. And I just found it interesting, Lyme disease and Rocky Mountain spotted fever. So out of all of the conditions that are the book, and references list, I just find it interesting with tetracycline, they name chlamydia, Lyme disease, and Rocky Mountain spotted fever as very specific conditions. So with our, I forgot. With the, I had another thought in there, and now I don't remember what that was. Rocky Mountain spotted fever, Lyme disease, adverse. I was checking the book because I thought I had a another note or a reference in here. I apologize while I'm making you wait. No, I apologize. I thought I had made a note on my PowerPoint to reference a page, and apparently it was a misnote. So, the other adverse reactions, the Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a syndrome where they will turn, there's actually two that are very specific. One's Red Man syndrome and one is Stevens-Johnson syndrome. And Red Man syndrome is just that. It's common with vancomycin. Basically, where for the trunk up, they turn red. It's not an allergic reaction. We can give, an NSAID or acetaminophen for the discomfort, but it's not an allergic reaction. It's just an odd thing. And I'll be honest, I have never seen in real life red man syndrome. I've only seen pictures of it, but I think that I might kind of freak out if I saw that. The Stevens-Johnson syndrome, that is more concentrated in the head, where they can get some edema, swelling, and may have some lesions. But it's not a common reaction. I put it on, an adverse reaction, but I put it on there because it's, we'll see it a few times, but again, Stevens-Johnson is not a common adverse reaction, but wanted to mention it. Now, vancomycin in the red man, that is a common reaction. So what else? So that takes up to our tetracyclines. So we have, make sure, reviewed our aminoglycosides and our penicillins, gone over cephalosporins and tetracyclines. So any questions so far? Let's see.
I don't have any questions. I'm good.
Okay, thank you. And if anybody does, I'm trying to also be mindful of the chat too, so you can all, and I think you can, there's some reactions, I'm gonna raise your hand or something, but so don't hesitate to anybody to stop me as I go through. See, it's hard. I want to move around. You all know how I like to move, and this is challenging. I may have to go up to campus by myself where they have the webcams that's got more room, so I can at least walk around. Okay. So now we're going to move on to our macrolides. I'm telling you, it seems like antibiotics go on forever and ever. So with our macrolides, again, bacteriostatic, so they're going to prevent the growth of microorganisms or of that bacteria. It said they're acid sensitive. So this, so they're enteric coated or buffered. What this means is even the acid in the stomach will react and alter the functionality of a macrolide. So they have that enteric coating. So an enteric coating, and I apologize, I thought we had talked about this, but I can't verify. The enteric coating is like what you see on an ibuprofen, that brown coating. It is a protective coating that prevents, or the goal is to prevent or delay the metabolism, the breakdown of that tablet or capsule while in the stomach. The hope is that it passes on into the duodenum, into the small intestine before it starts to break down, before it starts to metabolize. For most cases, it's to protect the stomach. With our anti-inflammatories, it's because they can cause GI distress, gastrointestinal distress, and bleeding and things. So most of the reason it's because of what it does to the body, the pharmacodynamics. But this one is the pharmacokinetics. What does the body do to the drugs? And it's because this drug, the macrolide, is acid sensitive. If it hits the stomach, and with that stomach acid, that hydrochloric acid, it will start breaking down sooner than what, and alter the functionality or the effectiveness of these antibiotics. So with this one, remember, anything that has that enteric coating, we do not want to crush, split, tell the patient not to choose. We don't want to disrupt that outer coating for any reason. And again, most of it's for our protection. This one happens to be for the protection of the medication. So with our macrolides, so look at this, it's mostly erythromycin and derivatives. So now with our aminoglycosides, they were myosin, gentamicin, vancomycin, but notice that the myosin, it was spelled differently. It was MI, where the macrolides are MY, erythromycin. So azithromycin, which is Zithromax, Biaxin, which is clarithromycin. So the mycins with the Y, fludoxamycin. There's always one to go in there, but mostly with the Y. These can be given orally. So we have tablets as well as liquid formations, and they can be given IV. So our macrolides are emycins. So what are some of our nursing considerations? So best taken on an empty stomach. So like our cephalosporins, I mean, not cephalosporins, our tetracyclines, take those on an empty stomach. And because it's enhanced, or the absorption is enhanced, we absorb it better. But macrolides can cause tummy upset, so it can be said taken after a meal or a snack. So it can be. It doesn't mean that we want to avoid it. Now, we'll get to some medications and other drug classifications later on where it's like absolutely don't take with food. This one we say it's better to take with water, but if you need to take with food, go ahead. The drug interaction, so theophylline, colchicine, other antimicrobials. So theophylline is a medication used for asthma and other COPD issues. Colchicine is used for gout. So macrolides, I would pretty much stick with the nausea, vomiting, diarrhea, and that it does interact with other antimicrobials. Again, I wouldn't worry as much about the theophylline and the colchicine. Now here's another one, a classification that can be a mouthful to say. And these are your quinolones. So your quinolones, it says excellent oral absorption. So we take it by mouth, they absorb great. But look, reduced by antacids. So remember with our tetracyclines, we didn't want to use antacids. That had to do with it binding and then causing other issues, the teeth discoloration and fetal skeletal deformities. With our quinolones, it's that the absorption is reduced by antibiotics. It interferes with how much of the medication that we absorb. So with our quinolones, those are our fluoxetine, ciprofloxacin, might have heard Cipro. I just found it interesting that Cipro is used for anthrax. Levofloxacin. Now I want to point out levofloxacin. Now see, I can't even say it. Levofloxacin, which is Levaquin. That Levaquin is with this black box warning below, with that increased risk of tendonitis and tendon rupture. That is more associated with Levaquin than it is some of the other ones with the Cipro, the ciprofloxacin. So this is one of those you need to put a little star by and remember. So kind of put in your head, anytime that there's a black box warning, you should be aware of that black box warning. And then remember that black box warning is something that the FDA, the Food and Drug Administration, has put out and said, okay, we're approving this medication, but you have to be aware that this can happen. This is the high chance of this happening, not 2%, like it's a high chance. So with our levofloxacin, Levaquin, more specifically, the increased risk of tendonitis, so inflammation of the tendons, but tendon rupture, and most of it's been the Achilles tendon. And that's a big tendon in the back of our calf. You can't walk without your Achilles tendon, but that's, what a way to find out is you're taking this anti-infective and all of a sudden you get this tendon rupture and now you've got a whole nother set of problems. But so our quinolones, the floxacins, and even more specifically, the levofloxacin, Levaquin, that black box warning with that tendonitis, increased chance of tendon rupture. Now, they do have the quinolones do have some phototoxic reactions, meaning, you know, not just photosensitivity, where more easily sunburned, but phototoxic. But the big thing on this is that tendinitis. If you're making little stars when I tell you to, or honing in, you probably have a lot of quiz and test questions, your study guide already going. Okay, let's do this. Let's see, it is about 1:48. So our next section is the sulfonamides. So we'll do the sulfonamides. We'll get up to antivirals. So we've got about 5 or 6 slides, and then we'll take a break at our antivirals. So break is coming up. So our sulfonamides. So this was one of the first groups of antibiotics, one of the originals. So with the sulfonamides, kind of like the cephalosporins, where cephal was the prefix that helped us to identify these medications, sulfonamides usually start with sulfa. So that's nice. So we have sulfamethoxazole, so Bactrim and Septra, sulfadiazazine, sulfasalazine, sulfa drugs, or sulfa. Now the sulfadiazazine, Silvadene, that's a cream. That's also in a cream, and it's really good for burns. But our sulfa drugs, first group of antibiotics, oops, sorry. So now here's another one of those things to put your little star by, is may increase the effects of oral anti-diabetic drugs and decrease the effect of oral contraceptives. So what does that mean? Again, if we've got a female patient that is taking a sulfa drug and they're using oral contraceptives, birth control pills, we need to remind them to take another form of, or use another form of birth control, because sulfa drugs will decrease the effectiveness. Now, if someone is a type 2 diabetic and they are on oral anti-diabetic drugs, then this can increase those oral anti-diabetic drugs so they can work a little too well. So we could go from a problem of hyperglycemia to a problem of hypoglycemia because those anti-diabetic drugs are working too well. So those two little notations for the sulfa drugs are things to be aware of and to keep in your mind. So what are some adverse reactions? It says check for allergies for other sulfur-containing drugs. So furosemide is listed. Now furosemide, we will talk about with our diuretics, with our antihypertensives, it's Lasix. But because it has sulfur in it, if they are allergic to a sulfonamide, a anti-infective, then they are going to have a cross allergy to other sulfa medications. So, and by the same token, if we have a patient who is allergic to Lasix or allergic to furosemide, they're also going to have that cross allergy to the sulfonamides, the sulfa drugs, the sulfa antibiotics. Also, this is another one that can cause photosensitivity. So that reaction in the sun, get sunburned more easily. And then the Stevens-Johnson syndrome. So what else with our sulfonamides? So here, this is something, so we want to make sure with our sulfonamides that they are getting enough fluid. So look, it says take 3,000 to 4,000 milliliters of fluid in a 24-hour period. That's 3 to 4 liters of fluid. But we also want to see that output. Take oral doses with food. So with our other medications, with our last two, we were taking with water. We didn't want to take with food. Didn't mean we couldn't. We just recommended that they didn't. But with the sulfonamides, we want to take those oral doses with food. I was looking for something else. Sorry, as I go through. So our sulfonamides. And if you're following in your book, I did want to say there were a couple of that I did out of order. There was a box about teaching about sulfonamides, but it didn't have any additional information than really what I had put on the PowerPoints. And then, like I said, I've realized I went out of order and didn't warn you all. So if you were following in the book, when we jumped from our macrolides and I skipped over some, there were a couple groups that I did, I skipped, we'll list them at the end, because there are so many different types of antibiotics that need to kind of cut them off at some point, and we focus on the big groups. The other one is in our book, vancomycin is listed separately. It's in its own little section, and I listed it with a little star with our aminoglycosides with our first grouping of antibiotics. And the big reason for that is, even though it is not truly an aminoglycoside, it falls in with the adverse reactions, the pharmacodynamics as the same as an aminoglycoside. Oh, and I apologize. One of the reasons I didn't tell you why we want them to take in so much fluid. The reason we want them to really push the fluids is because the sulfonamide can crystallize in the body if they're not hydrated well. So if we keep them hydrated, then we make sure the sulfonamide does not crystallize, and that we get maximum effects, and that it is processed through, the absorption, distribution, excretion, all of that in a timely and an appropriate manner. It's that crystallization with the water. So our miscellaneous antibiotics, so they are listed under miscellaneous, but again, you'll notice I didn't go into the monobactams, the carbapenems, oh, and I should have mentioned, in the book, they call them fluoroquinolones. I call them quinolones. They are the same thing. But again, cutting down some of these antibiotics. But as we go through some of our miscellaneous antibiotics, just the notes here. So clindamycin, so even though it has the ending just like our erythromycins, it doesn't fall into that category. But no, limited use. It is very toxic. It has a low therapeutic index, but it's very toxic. So we want to make sure that we're being safe. So they don't use it very much. The linezolid, that is or Zyvox, it is a newer treatment for VRE and MRSA, where it used to be vancomycin and gentamicin. Now we have a new player in the game. And again, they'll be used in combination. Flagyl, and we'll notice with that ending, that is almost like an anti-fungal with that ending. But Flagyl, the big thing with Flagyl, avoid alcohol. Put a star. Avoid alcohol, because it's not a matter of it might make you sick. It will make you sick if patients take alcohol and Flagyl together. In fact, for some that are have alcohol addictions, some prescribers will give Flagyl to help prevent those binges, or to deter people from drinking, because it will make you so sick. Just want to list macrodantin. And then again, the vancomycin, it's on its own, but we covered that with our aminoglycosides. Has the red man syndrome, could be a side effect, and that's where the upper body, the trunk, upper body becomes flushed red, but it is not an allergic reaction. Okay. Oh, shoot. I meant to cover up these answers first. I meant to do that. I need to change that. So our classroom response question, just to kind of check our knowledge. So we have that patient who has a prescription for a sulfa drug, for a UTI, urinary tract infection, also taking an oral contraceptive, an oral sulfonylurea anti-diabetic. So it doesn't matter that we didn't know what, if we didn't know what a sulfonylurea was, but it's an anti-diabetic drug. And phenytoin for history of seizures. Which drug may pose a potential serious interaction? So with this, can't get my, there we go. So the answer is D, all of these. And I did not have, ooh, I don't know how that got on there. I did not have seizures on there. So I apologize for that. It's or seizure medication, interfering with seizure medication. The oral contraceptives and the oral anti-diabetics are the big ones. But again, reduces the effectiveness of our oral contraceptives and increases the effectiveness of our oral diabetic drug, which may not be always be the thing we want. Better is not always better. Okay, and then our last slide before we take a break and before we talk about our antivirals. So our nursing considerations for our antibiotics, just in general, is remember that if we are going to do that culture and sensitivity, do that before we start our anti-infective therapy. We're going to watch for signs and symptoms of improvement. So if they had a fever, is there a fever? Excuse me, is our fever being reduced? If they've got drainage, are we seeing changes in the drainage? Again, those signs of reduced infection. Those vital signs returning normal, getting those subsequent culture and sensitivity tests, making sure they're coming back normal. And again, just the general appearance, drainage, redness, if it is a wound, patient is feeling a little better, not as lethargic, and monitor for those adverse reactions. So we're always going to be on a heightened awareness for an anaphylactic or allergic reaction with our antibiotics. Okay, so that gets us to our antiviral section. So any questions on the antibiotics or our antibacterials? If you all don't have any questions, it is about 2 o'clock, 2:01. By the time I quit talking, it probably would be 2:08. No. So we'll take about 2:12. So come back at 2:12 and we will go into our, we'll finish up our chapter 12. And I'm not sure, we'll start chapter 13 if we have a chance, but the other thing I want to do today is for our lab piece is to take a look at different drug labels, medication labels. So we can get used to seeing what is on the label, how to look at those. So when we start doing, when we get deeper into our dosage calculations, that we know what numbers that we are looking for, or if we get a calculation problem that's got a lot of numbers in there, realizing which numbers we need for our calculation and which ones are just extra numbers that we don't really need. So, see, I told you. Now it's 2:02. I will see you at 2:12 in 10 minutes. Thank you. on. I apologize. I'm so sorry. So with our type A and type B flus and these medications, it's again to shorten the duration or decrease the intensity. It is not going to cure the flu. It is not going to get rid of influenza A or influenza B. It is really to manage those symptoms. They can cause nausea and vomiting. Now, the other thing with this is that these have to be started within about 2 days. I think some docs have extended it to 3 days, but between 2 and 3 days of when the symptoms start. If they start later than that, then they don't recommend taking it because they don't find it's going to be effective. But again, it could possibly change the intensity or the duration or lessen the duration of the flu, but it's not going to completely get rid of the flu. The other thing is, once they take this antiviral, once they take this thing that's going to attack the flu, they don't want to get a flu vaccine, because then this antiviral will still be in their system and will possibly attack or negate the flu vaccine, the antibodies within the flu. Because we do introduce a little bit of that flu. That is what the flu vaccine is introducing a little bit of the dead flu virus to help spark antibody production. But if we give an antiviral and go in and kill it, then we are not going to elicit that response necessarily. So our antivirals for hepatitis B and hepatitis C. So hepatitis B and hepatitis C can both be treated with interferon. Now, there's a whole lot in the textbook about interferon. There's a whole lot about a lot of these antivirals. We could spend probably 3 months on antivirals alone, but we don't need to. We're not going to be immunologists. We need to know what is important. What do we need to know that's important as nurses to safely take care of our patients? So again, with our antivirals, the same general side effects or adverse effects, except now this one. And so here's another one to put a star by. With our interferon to treat hepatitis B and hepatitis C, that it can cause birth defects and fetal death. So obviously this is not a medication that we want a woman who is pregnant taking. So big black box warning on there. Hepatitis C can be treated with sofosbuvir, but again, another antiviral. So hepatitis C is hepatitis C. That thought went. Okay. So again, with our antivirals, remember those are our non-HIV medications to treat viruses. That we had a listing of the virus, some of the antivirals and the conditions that they treated. But remember, the big thing about antivirals is that they manage the infection. They may not eliminate it. It may not cure it. The other thing about antivirals is that they are not meant to prevent the spread of an infection, or they won't prevent the spread of an infection. We hope they decrease by the spread of infection by other means, through contact. But if someone has a virus, they have the flu, and they take an antiviral and they cough and spread those droplets, it just means it's not going to prevent those droplets from spreading the flu, if that makes sense. Okay, so our antiretrovirals. So remember, if we talk about an antiviral, those are our non-HIV medications. Our antiretroviral, those are HIV medications. And I see that I have a list of different antiviral medications. Now I will tell you, the text or the book goes into much greater detail about treatment of HIV and different drug combinations. I'm not going into that depth because as we talk about these, we'll find that there are different combinations of antiretrovirals that are used. And even when a patient is on that combination, there is constant monitoring and adjustment of these medications. And it is so challenging for a healthcare provider to keep up with that treats this on a regular basis, that for us to try to manage and keep these straight, I think is a little more than what we need to do. We need to be aware of what our antiretrovirals do, be familiar with a couple of the names of these and some general information about the adverse effects, what to watch out for. Let's see. But I don't, nursing under our nursing considerations, but we're not going to spend much time on the antiretrovirals. So the slide, let me see if the slides. I guess my slide advanced and somebody else's didn't. Let me go back. Okay, is everybody seeing, is there somebody not seeing the list of antiretroviral drugs up? Just want to make sure that everybody's got the same slide up. Apparently there was a lag. Okay.
I see mine.
Okay. Like I said, sometimes it's just an individual thing, like me moving like a robot in my own screen here. So again, those antiretrovirals. So adverse effects, there are so many. There are so many adverse effects. There are so many different ones. It depends on the drug. And then you put these combinations together and it changes and potentiates, and again, there's so much to keep up with. So what we need to know is there are numerous adverse effects, and it varies with each drug. And that because of these adverse effects, a patient may be started on a medication or a combination of medications, and the adverse effects may be something they just can't deal with. Maybe it causes, just god-awful diarrhea. So they may need to make those changes, make modifications, not only to the medication itself, but maybe to the dosages. So the goal is to find this combination, find this regimen for that particular patient that not only controls the infection, but also that they can tolerate all of those adverse effects. And that's where that balance is. So we can't say, all HIV positive patients will be started on this medication or these medications, and then we progress to this. It's just that those variables that are done based on patient response. And again, they could be doing fine with a combination of medications, not having adverse effects or not anything they can't deal with, but maybe now the antiretroviral is not working as well. So again, they may have to change course of those medications during out the course of the illness. There's lots and lots of drug interactions with various classifications, whether it's other anti-infectives or some of our cardiac medications. So antiretroviral drugs, this would be one. If I had a patient on it, I would just have to pull out the book. So I would, for studying purposes, know kind of, the basics that, let me go back, that again, most of them, the Endinvir, what is the goal? The goal is to find the regimen that has most tolerable adverse effects, but the best control of the infection. Know that these medications will have to be adjusted. We want to make sure that, make sure they know how to apply these medications, how they need to take them. So whether it's an ointment or a powder, how do they apply those? So that's something, that's with all medications. So some of these, I think with these nursing considerations here, they're very generic for most of our drugs. Instruct the patients on the importance of taking these medications exactly as prescribed. That's common with all of our anti-infectives. Patients have a challenge in finishing those. We feel better, we quit taking them, and we've got half the dose left or half of the prescription left. That's not what's supposed to happen. We're always going to monitor for those adverse effects, because remember, with our antivirals, our antiretrovirals, we have that chance of hypersensitivity, just like we do with our antibacterials, our antibiotics. And then with just like our antibacterials, with our antivirals, we're going to monitor. We want to see, are they making improvement? Is there, can we see those therapeutic effects? Now, granted, depending on the nature of the virus, depends on what type of effects we will see. So somebody recovering from influenza and seeing therapeutic effects is going to be very different than someone recovering from shingles and their demonstration of therapeutic effects. So our antivirals and our antiretrovirals. Now I laugh because I stumble over a couple of these words, and here's one that I stumble over a lot. Anti-tubercular. So TB, treat TB. So the first line drugs, and we've got the INH. The INH is, these are all of our first line drugs for our anti-tubercular. And our anti-tubercular drugs, and I apologize, I usually give you page numbers as we go through. These start on page 565 with it's in our anti-infectives, but our anti-tubercular drugs. INH is really, while these are all first line drugs, that is the number one drug that is prescribed for for TB. So what are our adverse effects? Fatigue. Hey, look, nausea, vomiting. Isn't that a surprise? But the fatigue, and that is just, it's not just, oh, I'm kind of tired. It's like, oh, I am worn out kind of fatigue. It can cause some numbness and tingling of the extremities. Now, and I find this interesting, that even with some of our other medications that cause nausea, vomiting, and diarrhea, we don't always see a loss of appetite, but with our anti-TB drugs, they do cause a loss of appetite. So not only are we nauseated and vomiting, then we're not even hungry when we're not sick. So the other thing is as if it starts to reach toxicity, starting to have liver effects, we'll start seeing jaundice in our patient. And remember, jaundice is that yellow tint to their skin that we can check even on, it's easier to check with lighter skinned people, but with people of color, and you can check on their chest, on a hand. Well, I'm used to babies, we would check on their nose or their forehead, but basically you press and you blanch. And when we talk about blanching, is no matter what exterior, what our skin tone or color is, that when we blanch it, it takes all the color, the melanin away briefly. And so it should appear white very briefly. Now, when we do that, if someone is jaundiced, that we'll see a yellow tint to it. So check for jaundice with our anti-TB drugs. What are nursing implications? Again, those liver functions, because again of the effects of the liver that INH and these other anti-TB drugs have, we want to monitor the liver functions to make sure that it's not causing liver damage. And it says, especially in our elderly patients and those who use alcohol. Well, elderly patients, because their liver function decreases over time because of age, and with those who use alcohol, because of the alcohol use can cause changes in liver function as well as in the liver itself. So we want to make sure that they're able to metabolize and excrete these medications. This is a tough one. So we talk about finishing medications and people not finishing their 10 days of antibiotics or their 2 weeks of antivirals. Look at this, anti-TB therapy may last up to 24 months. So that is another challenge, is making sure that the patient remembers to take this medication for that length of time and to take it every day, same time as ordered. Because again, they start feeling better, so they quit taking the medication. Now the challenge, if they don't complete that, is they can have an exacerbation or a recurrence of TB. The other thing is while they are infective, or if they don't finish and become infective before they know it, now who have they exposed within their world, within their home, within their workplace? So they need to stick with this regimen, as tough as it can be. Also, be aware, now look at this, urine, stool, saliva, sputum, sweat, or tears may become reddish orange. Even contact lenses may be stained. So here's a little star. So this is another common question. And that's what happens. The INH can tint body secretions orange. Now, and when it does turn those secretions orange, then it can also turn things that come in contact with that orange. So that's why it talks about the contact lenses. It would be if you cried, you could wipe and you'd think, oh, I've got orange tears. Now this is not related to jaundice, even though the color hue and the color family is the same. So those are the anti-TB drugs. So remember the big one, there are several medications, but INH is the most commonly prescribed, that with common side effect is the fatigue. Again, fatigue can cause some numbness and tingling in the fingers. Nausea, vomiting, and a loss of appetite, and then jaundice would be related to liver function. The other thing is, remember, it can stain. It can stain our secretions orange, so we need to be aware of that. And it's very important to take that medication for all 2 years. Usually I think it's about between 9 and 18 months that they normally take it, but it can be up to 2 years. Is this one? So we are in the last bit of our anti-infectives. So with our anti-infectives, we're going to wrap up with antifungals. So anti-bacterials are the antibiotics, antivirals for viruses, antitubercular to treat TB, and now we have our antifungal drugs. So with our antifungal drugs, again, we don't have as many of these as we do as our antibiotics as well. So listed a few of the antifungal drugs there. So you see the gracefulvin, it says treats tinea infections. So tinea infections, tinea is a fungus that is named for where it's located. So if it is a fungal infection of the head, it's tinea capitis. If it is of the feet, it is tinea pedis. So which is athlete's foot, by the way. So it is named for where it is located. So the tinea infections. So the Gracefulin is for tinea. We also, you may have heard or will hear of amphotericin B and nystatin. So with the nystatin, we often see that for thrush, for especially in our older population or those in chemo, maybe a swish and spit kind of thing. And it's to help keep yeast, candidiase, under control. So nystatin. The third bullet point, notice that all of these have the suffix of zol or iazole or zol. We'll just say zol. Those are antifungal drugs. So when you see the zol ending, it is an antifungal. So while many of these can be topical, many of these can be oral. Some of these are also injectable. But I did want to show on this bullet point the drug of choice for the treatment of many severe systemic fungal infections is amphotericin B. So someone has a systemic fungal infection, we're going to give them IV amphotericin B. So the other drug choices are going to be dependent on the drug, the type of infection or where the infection is located. But here's another star. The drug of choice for a systemic fungal infection is going to be amphotericin B. And so in the back, after the anti-TB medications, anti-tubercular, it lists antifungal drugs, and it kind of lists them all together. It doesn't break them down into separate classes, but there is a box on page 571 that says other antifungal drugs. So many of these are listed there in the in that box. So what are adverse effects of our antifungal drugs? Hey, nausea, vomiting, diarrhea. So I think we can pretty much put for all of our anti-infectives, it's going to be nausea, vomiting, and diarrhea. Now we're going to add to the anti-TB drugs that we're going to add that loss of appetite as well, but all of them are going to be nausea, vomiting, diarrhea. Then we also are going to add headache into this, to our antifungal drugs. Now I mentioned amphotericin B is the treatment of choice for a systemic fungal infection, but we need to know some adverse effects very specific to that outside of the nausea, vomiting, and diarrhea, because these are not always, can be some pretty severe. So with the amphotericin B, so it can cause cardiac dysrhythmias, so alternate the rhythm of the heart. But look at the toxicity. So neurotoxicity, be toxic to the nervous system. It can be toxic to the kidneys. So this is not, it's not a light drug, I should say. It can cause some severe adverse effects. The other, look at, to go along with that neurotoxicity, visual disturbances, ringing ears, numbness and tumbling, or tingling and numbness in your hands and feet. Convulsions. So amphotericin B does have a lot of adverse effects. But look at this at the very bottom, and I would say this is another one to star. So if there was a question that said your patient who is on IV amphotericin B complains of nausea, chills, upset stomach, and has a fever, what are you going to do? Well, we're going to do nothing. And I know that sounds terrible, but because this is an expected set of side effects or effects, we know it's going to happen. And again, this is one of those, it's not, it might happen. Would be surprised if it didn't happen. That we will treat the headache, we will treat the nausea, we'll treat the fever, but we won't stop the medication. So big note for that with the amphotericin B is not stopping the medication, but treating those symptoms. And then the last part for our antifungal are nursing considerations. So if there is a patient that's getting that IV, he's probably more than likely going to be amphotericin B, but if they are getting that IV, we want to monitor that infusion every 15 to 30 minutes. We want to make sure that the patient's doing okay. We want to make sure that they're not having any of these adverse effects such as those dysrhythmias. Also, if they start to kick into some of those expected, the fever and chills, we want to make sure that we're treating those symptoms. So check those patients every 15 to 30 minutes, little star. We want to monitor their INO. And again, monitor those therapeutic effects. Are they feeling better? Are they getting more energy? Are we seeing improvement in their vital signs? Are they other signs of infection, inflammation, are those decreasing? So looking for those signs of therapeutic effects. And then monitor for those adverse effects. So those are our anti-infectives in a nutshell. So any question on chapter 12, our anti-infectives? So it doesn't look like anybody has questions right now. So I'm going to stop this. Maybe stop. Okay, a couple things. We're going to take a break here in a second, but a couple things I wanted to show you is that I will get sent out. I was updating this today. So this is a listing of drug classifications by my shared screen is paused. Okay, I'm not sure why. It says my shared screen is paused. I'm going to stop share. What I'm trying to show you, and I will get it posted up in Populi, but like I said, we were updating from earlier, is a list of drug classifications by prefix and suffix. Okay, I don't know why it keeps doing that. But so broke it down. So just kind of tell you what it is. It's like it has the suffix "-cillin" to say, an example, penicillin, amoxicillin, drug class are penicillins. So I've got all of the anti-infectives, the VIRs, which, you know, the antivirals. There are other medications on this list that we as a group haven't gotten to, but that we were building from the other class. But I'm going to go ahead and I'll get that posted. So as you go through it and are starting to learn some of these drugs and learn some of these classes, that you will get to the point where you know where OLOL is a beta blocker. And so you know any drug that ends in that, these are the kind of effects or adverse effects I'm looking for. So, and I apologize that it does not want to share right now, but I'll get that posted because that might be helpful. Just going to add a few that we had done today in this morning's class. So I'll get that up for you. Okay, so it is now 3:02. I guess we'll be back at 3:12. One thing I want to do is take a look at some of those drug labels and then check on some calculations with you all. So I will see you at 3:12. Okay, let's see. Remember to hit the record now. Trying to find the I think the problem is I've got too many windows open on my computer. So it is struggling to find, close some of these. Let me blow this up. Let's see, host share screen is cooperative this time. Okay, so far from my side, it looks okay. Let me know if you are not able to see the drug labels. Okay, so as we go through the drug labels, a couple things that we want to look at, and I wish I could make this darker. So I'll blow these up a little bit, and I'll move these around so we can look at these. But one of the things we want to look at, we talked about drugs have a generic name and a brand name. So on this label, the Carafate is the brand name. The Sucralfate is the generic name. So we will only find one Carafate out on the market, marketed by Aventis, but we might find different formulations of Sulcrafate. So that's the difference in that generic name and the brand name. Now this, the famotidine, this one, let's see. Sorry, checking the chat. Where'd they go? Thought somebody had a chat, but I can't get it to come up now. Ah, did not mean to do that. Okay, I apologize. Oh, did I say memorize the brand names? No, you do not need to memorize brand names. We give those as examples, but anytime that that I would give an exam or a quiz, and usually what you'll see listed in any type of question, it will give the generic name with that brand name in parentheses. But we try to stick with more the generic names. One, because it's hard to keep up with all these brand names. So this one doesn't have a brand name listed. It just has the generic name. Is this PDF on Populi? I believe so. I'll check. If it's not, I'll make sure it is. I'll make sure that is. I was trying to upload a lot of documents today. And as we get things created for the other class, I'm trying to get them transferred over for you all so you have access to those. Oh, I better write that down too. Images on Populi. You know me, I got to write it down. Just because I'm at home, it doesn't help with that memory thing anymore. So here when it talks about dosage strength, so the dosage strength, this one is 600 milligrams. So this particular formulation, it is a tablet. I don't know if you can see that right here. It's a tablet. So when it says 600 milligrams, oops, that means that each tablet has 600 milligrams, not a total of 600 milligrams in this bottle, but that each one of those tablets have 600 milligrams. Now this one is a little different. So, and in how it's listed. So it is still a tablet. We can see the formulation is still a tablet. But what this is saying, it's 250 milligrams, which is equivalent to 400,000 units. And penicillin and some antibiotics have different measurements as well. Penicillin is one of the big ones. It's also measured in units, but we don't think units in that way, in the way we administer. That's more of a chemist pharmacy formulation measurement. We use the milligrams, so that's why it's listed both ways. So 250 milligrams in 4,000 units. Now, in the off chance that a provider would write, give them 600,000 units of penicillin, this would come in handy there. But I don't know that happens anymore, that we go by milligrams instead. So this one says identifies the structure and composition. Oh, maybe I need to make this one smaller. These labels are a little bigger. So the structure or composition. So this one, this natural fiber supplement, it tells you it's a granular drug that we add it to a liquid. So we don't just take the medication dry in that powder. These are, sorry, these are a little smaller. Blow these up. So this is showing an oral solution. So we have liquids that are oral solutions. Oop, having trouble highlighting just right there. The oral solution, so that potassium chloride, that is, it says it's 15 milliliters of potassium chloride, an oral solution. And in that 15 milliliters is 20 milliequivalents of potassium chloride. So when we are doing a dosage calculation, when we talk about what is that concentration, what is that, if the concentration is 20 milliequivalents per 15 milliliters. I'm writing that down, so that may be one we can practice with.
Like, so would there be like other stuff in there then? Like other...
If we were going to do a calculation?
Yeah, like, okay, so it's 20 milliequivalents per 15 milliliters. Is there other stuff then in there besides potassium chloride?
There may be some little additives to add the bulk, but it's that 15 milliliters. And I'm not sure, I'm hoping I'm answering your question. It's just, there's 15 milliliters of solution that contains that 20 milliequivalents. Now, again, there's some flavoring things in there.
Like you're not saying like 20 milliequivalents per every 15 milliliter. You're saying it's like the whole bulk of the like oral dose that you're getting.
Yes. And then when this one, and it's hard to tell, this one is actually like a little individual cup. It almost looks like a little to-go condiment cup kind of thing. And so usually it would be considered one dose if the provider ordered 20 milliequivalents. But we're saying, so this one little cup has 15 milliliters of liquid, and in that 15 milliliters of liquid is 20 milliequivalents of potassium chloride. So and the reason I wrote it down, so we can practice, let's say it's in a dosage calculation problem, let's say the provider only wanted to give 10 milliequivalents. That would be why we would need to know the 20 and 15. But we'll do that when we do a dosage calculation practice. And I've marked that one down. But so just to keep in mind that in a dosage calculation, when we're talking about the concentration, this is 20 milliequivalents of medication in 15 milliliters of liquid. That's how this one is packaged. This just happens to be an individual dose. Now, if we look at the one next to it, the anapsine says it's 5 milligrams and for every 2 milliliters, which breaks down to 2.5 milligrams per milliliter. Now, why did they write it down that way or package it that way? Because if you look in the upper right-hand corner, this vial, because this is an injectable, this vial or ampule, I'm sorry, it's an ampule, 2 milliliters, has 2 milliliters in it. So this whole ampule, I've got all my props across the room. But this ampule has 2 milliliters in it. And in this 2 milliliter ampule is 5 milligrams of anapsine. If I take 1 milliliter of it, that means I've got half of the amount of the ampule volume, which means I've also got half of the amount of the medication. So 1 milliliter is 2.5 milligrams of anapsine. So in our dosage calculation, we could use either one. It lists, because of the way it lists it, but this again is that concentration. So when we're doing like, if you like the D over H, the desired over the have times the quantity, this would be your have would be your 5 milligrams, your quantity would be your 2 milliliters. If you're doing, and it will make more sense when we do this, when I do this on a whiteboard for you. So what I'm doing now is writing down these concentrations so we can do some calculations very specific to these. So that might make more sense than just kind of talking about it. But just trying to, what we want to do right now is get used to these drug labels and how to decipher those. So again, we've got, this is tablet. So we've got the oral solution was the potassium chloride, an injectable solution was our anapsine. Now look, and our potassium chloride does have oral right on there. The anapsine does say injection right on there because you can't cross one for the other. You can't take an oral solution and inject it. People have died doing that. And you can't take an injectable and give it orally. They don't work that way. They don't function that way. So we can't cross the forms or the routes in that way. So with this other tablet, I'll blow this up a little bit. With this tablet, of terbutaline. So terbutaline, that is the generic name. It does not have a brand name on there. Lannett is the manufacturer. I wanted to mention, you'll see this NDC number. That is a national drug number that is assigned to every medication, whether it's over the counter or prescription, but that is a national drug number that is assigned. So with this tablet, it's saying this tablet has 2.5 milligrams. So while there are 100 tablets in this bottle, each tablet is 2.5 milligrams of terbutaline. So nitroglycerin. So nitroglycerin, now look, this is an extended release capsule. So this isn't a tablet, this is a capsule. Now with our extended release capsules, remember, because of their extended release, they are manufactured to release a certain amount of medication over time. We do not want to alter or change the integrity of that capsule, meaning don't break it open, don't crush it, don't do anything to it. It needs to be ingested whole. Now this time extended release capsule, which you may see listed as XR for extended release or ER extended release. This is 6.5 milligrams. So it means each one of these little nitroglycerin capsules is 6.5 milligrams. This bottle happens to have 50 capsules in it, but each capsule individually has 60 milligrams. I'm gonna have to make this smaller because I don't know what we're coming at. So again, the supply dosage, trying to blow up. So on this heparin, oh, sorry, go away, blue. So on the heparin, so it says heparin sodium, 500 or 5,000 USPs units per milliliter. That's a specific measurement for heparin. Look, it says for IV or SC use, that's subcutaneous. SC was a very common abbreviation for subcutaneous. That is now one of those that we're not supposed to use anymore. So we won't use that, but I wanted to explain what SC was. So this heparin can be given IV or subcutaneously. Notice it says it's 1 milliliter. So it has 5,000 units in it, but it's in 1 milliliter. So that is that concentration, that is that dose. But very similar to those others where it's 20 milliequivalents in 15 milliliters. Look also this warning, and I'm kind of surprised. Oh, this 5,000 USPs, this is something that we need to be aware of. Heparin has different concentrations. So it might have 5,000, it might have 100, it might have 1 to 10,000. So we need to see what this number is on our heparin to make sure that we are giving the appropriate concentration of heparin. Not just the correct amount as in milliliters or number of units, but also that concentration. So this one, got a question. Yes, I did. Somebody mentioned, didn't I just talk about that with the babies? Heparin was one of those that caused some infant deaths in children's in Indianapolis about 12, 15 years ago because of the heparin concentrations that got mixed up. So very sad thing. They have changed the labels now. They're no longer all brown labels, so that does help. But again, just showing this is 5 milligrams per tablet. This Ritalin has 100 tablets in this bottle. This Nubane on the far right, it's an injectable. It says 20 milligrams per milliliter injection. Now notice it says 10 milliliter multi-dose vial. So the concentration, so if you're going to figure out, you know, the provider says, you need to administer 10 milligrams of Nubane and you need to figure out how many milliliters to give. So in that calculation, your 20 milligrams per milliliter, that is going to be what your ratio to proportion is set up. That is what your dose over, your desired over half is, or in your dimensional analysis. That is the concentration you use. The 10 milliliters, and you'll see this in some practice questions and some NCLEX questions, it'll throw that 10 milliliters in, and it's a number you don't need to find out what an individual dose is. What that 10 milliliters, when you might need that, is saying, okay, if each dose I'm giving is 20 milligrams, which is 1 milliliter, how many doses can I get out of this 10 milliliter vial? Well, if each dose I'm giving is 1 milliliter and there are 10 milliliters, I can get 10 doses. So again, you'll see some questions that will have the volume of the container on there, but we don't need it necessarily to compute the calculation. And I do have some examples of that. I've been accused of being tricky. It's not a matter of being tricky. It's giving you examples of calculations and questions that you may see on NCLEX that again is giving you all of the information, and it's part of our job is to figure out what information do we need to complete that calculation. So this is one of those that is usually, unless we need to know how many doses we're going to get out of that vial, then that 10 milliliter multi-dose dose is multi-dose vial is extra information, additional information. But I've got lots of practice for you. Let's see. I have to get this one smaller. So this one, I guess I need a little smaller. So there we go. So at the bottom it says 480 milliliters, 16 fluid ounces. So this one is just showing in metric measurements, the 480 milliliters, as well as in a household measurement, 16 fluid ounces. So remember, that's one of the calculations or one of the conversions I said we need to know is milliliters and ounces. That'll be frequent, especially when you're calculating your I&O. So when you're calculating your intake and output for a patient, they may have a 4-ounce juice, but when you record that, you're going to have to record that in milliliters. Like, okay, 4 ounces, how many milliliters is that? Hey, 30 milliliters is an ounce, 4 times 30, that's 120 milliliters. So we need to know that conversion. So they did put the household measurement on this particular bottle, but we won't necessarily use that as providers. We're going to be using the metric system to stay consistent within medication administration. Now I will tell you some of these labels are old. I probably might need to update. I've used these labels for a little while. But for what we're looking at, the different elements. So trying to reduce error. Oh, let me get bigger again. So this is insulin. So look, it says it's Novolin R, which is regular. Novolin R. Now see, Novolin has, before the big R for regular, it has a little R for registered trademark. That's because Novolin is a name brand. So Novolin is that brand name, and then insulin is that generic name. So this is regular human insulin. It is, so it says 10 milliliters. Now that means the whole vial contains 10 milliliters. What it's also showing us is that it is 100 units per milliliter. Now, one thing to be aware of with insulin, and even though it has milliliters on the vial to show us what the volume is, and even though it shows us how many units per milliliter, please understand when we draw up insulin and when we administer insulin, we do it by units. So we do it by units, not by milliliters. So always, always, always by units. And remember, insulin is one of those high-risk medications that when we draw up insulin prior to administration, we have another licensed provider check our syringe because it is such a high risk medication. So but I do want to point that out. So it does have the volume to show us how much is in there and the units per milliliter. But again, with the calculation and administration of insulin, we will always use units. Safety first. Here we have the Naprosyn. So Naprosyn, again, that's a brand name. I can't tell, it's got a little R there, but Naprosyn is the brand name. Naproxen is the generic name. Naprosyn was the original, and that was actually when it was prescription. What we see now is Aleve with our naproxen. So this is 250 milligrams. Each tablet is 250 milligrams, and there are 500 tablets in that bottle. So I think you're getting the gist of those. Let me see, let me scroll down. Did we get any other? Oh, administration route. I did point out on a couple of these already where it had the administration route. So here is Narcan. So it says 0.4 milligrams. Notice they put the 0 before the decimal. Again, for safety, when we talk about that leading 0, because there was not a number to the left of the decimal, they put that 0 in. So 0.4 milligrams per milliliter. So each milliliter, if I draw up a milliliter of this medication, it's going to have 0.4 milligrams in there. Now it's also packaged in an ampule. And it says that each ampule has 1 milliliter. So if I'm drawing up the Narcan, the whole ampule, I am getting 0.4 milligrams. It's also saying that this is an injection formulation, and it can be given intramuscularly, subcutaneously, or IV, intravenously. So it can be given all three of the major ways of medication administration parenterally, injectably. So telling us how that is administered. Scroll over, trying to scroll over. Doesn't want to, there we go. So we have our nitroglycerin. So when we get to our cardiac meds, our anti-anginal medications, we'll learn more about nitroglycerin. So nitroglycerin is the generic name. Nitrostat is the brand name. These are tablets and they're sublingual. So that means this is the only way to administer this particular formulation of nitroglycerin is sublingual. So that is held under the tongue and dissolved. It's not swallowed. It's not chewed. It's not sucked on. It's dissolved under the tongue. And it's saying each one of these sublingual tablets is 0.4 milligrams. The numbers in parentheses, those are apothecary weights. That is 1/150th of a grain. And it really wasn't that long ago. It's only been in the last 10 years that we stopped using and stopped having to learn the apothecary system on the healthcare administration side. So yes, we had a whole nother set of conversions and calculations we used to have to learn. But now those are really for people who make drugs. They've gone to that more standard milligrams, grams for safety as well as for ease of learning and administration. So here is an oral. So this is furosemide. So it is, that is a generic name. This Lasix would be a name brand. So this is an oral solution. So it is saying right there, furosemide, oral solution, 10 milligrams per milliliter. Each milliliter contains 10 furosemide, 10 milligrams. It's also saying that if in the upper, well, mid-right, that it's 60 milliliter bottle. So that means this bottle has 60 milliliters of furosemide, but if I only take out 1 milliliter, I'm getting 10 milligrams. Now, notice the dropper, that it has a dropper with this. I will tell you for safety in medication administration, if a medication comes with its own dropper, we need to use the dropper that it comes with. Many times they are calibrated specific for that medication, so we need to make sure that we're using that dropper and not to cross between them. Now, some of them, it may be a little easier if we know exactly how many milliliters we're giving, but again, safety, use the dropper of which it comes with. Small here again. Should have had a printed copy so I knew what was coming up. Okay, reconstitution. So some drugs are dispensed in a powder form. And one of the main reasons for that is they last longer. They have a longer shelf life in a powder form. And many of the antibiotics are like this, particularly the injectables and then the oral solutions. We don't have to reconstitute tablets, so don't know where I was coming with that. So they have the powder because usually once it is mixed, once it becomes a liquid that we are either going to ingest or a liquid that we're going to inject, that it's only good for like maybe up to 10 days, 10 to 14 days. So we don't want to pre-mix all this stuff because we would be wasting a lot of it. So we will get a powder form. And I keep looking over at the box because I want to show you all some of these things. One second. I'm back. So we've got our fake antibiotic. This is a demodose of amoxicillin, but it's in a powder form. And it may be packaged like this. It will have directions on the package on how to appropriately, what to mix with it, how much to mix with it. And so this is the oral dose. We also have, I don't know if you can see this, sorry. One thing, if you've got a powder and it's stuck, you want to tap it because injecting the liquid in there will not necessarily loosen it. I don't know if you've ever made something like hot chocolate and you get that pocket of chocolate powder that just won't break up. So we want to loosen the powder before we add any mixture. But again, powder forms and with very specific directions on, again, what to mix and how much to mix. So on this Zithromax, so Zithromax is the brand name, azithromycin is the generic name. This formulation, it says for IV infusion only. So it's for injection, but we can't give it IM, we can't give it sub-Q, we can only give it intravenously. It also says it is equivalent to 500 milligrams. So once we mix this up, there will be 500 milligrams. So when we look to the left, it gives us those reconstitution or constitute. So when we say reconstitute it, it means to add liquid and make it, or add a diluent. A diluent means to dilute it, is the liquid part. Add the diluent, and we're going to constitute it into a liquid. So it says constitute to 100 milligrams per milliliter. So when we follow these next directions, what we will get out of our medication, the total medication, will equal to 100 milligrams per milliliter. So it says with 4.8 milliliters of sterile water. So that means I need to make sure I'm using sterile water. Not normal saline, but sterile water. It's not my choice, it's theirs. Because if I mix it with normal saline, it may inactivate the drug, it may, we don't know what'll happen, but it says to reconstitute with 4.8 milliliters of sterile water. So what I will do is I will take a syringe and I will draw up 4.8 milliliters of sterile water. And then, and I know I was using this vial, it's an injectable. So then once I drop my 4.8 milliliters of sterile water, I'm now going to take my Zithromax, my powder, and I'm going to inject that 4.8 milliliters of sterile water. And I'm going to mix it up and mix it up. And what happens when I mix it up, even though I only added 4.8 milliliters of water, of the sterile water, it's actually gonna, because of the space that the powder takes up, it's gonna give me 5 milliliters. So I will now have 5 milliliters of liquid. So that's where on this label, if we go back onto the label where it says it is equivalent to 500 milligrams. And on my reconstitution, it says if I follow these directions, I'm going to get 100 milligrams per milliliter. So my concentration is 100 milligrams per milliliter, but I have a total of 5 milliliters with 500 milligrams total volume in there. Reconstitution. So we will practice some problems on reconstitution. Let's see. What's this one? This is for, this is for Vanton. So what are these? So this is an oral suspension. So this will be more along our lines of this type of a bottle. So the directions, it says for mixing, shake bottle to loosen granules. Add approximately 1/2 of the total amount of distilled water required for reconstitution. Total water is 29 milliliters. Shake vigorously to wet the granules, add the remaining water and shake vigorously. It's like, oh man. Okay, so now I need to go back and reread these directions. So it is telling me that I need to add 29 milliliters of water. Okay, I've got my 29 milliliters of water. Pretend this is water. I've got my 29 milliliters of water. So I've loosened my granules. And this is distilled water, by the way. It said very specifically distilled water. And it said add about half of that. So if I've got 29 milliliters, I'm going to put about half of that in there. I said I'm going to shake it. I'll put the top on. Shake it to get those granules wet. And then I'm going to add the rest of my distilled water and then shake it vigorously. So once it is all mixed up, once I have followed those directions, I will, it says each 5 milliliters of suspension contains basically 100 milligrams of the medication. So each 500 or each 5 milliliters contains 100 milligrams. So that's what in the center right here where it says 100 milligrams per 5 mLs, that's telling me once I have mixed this appropriately by those directions, that's my concentration. So if I'm going to be doing a dosage calculation, this is the concentration I would use, 100 milligrams per 5 milliliters. Now, what's my total volume? Well, I've added that in. Total volume, I end up with 50 milliliters. So there's 50 milliliters of liquid in here, but if I divide that out, every 5 milliliters is going to have 100 milligrams. So all different ways to write and different types of labels that we'll see. I know we're getting close on time. Let me see if I can. Oh, I wish I could. Let's see. What is this one? don't know if I can rotate that. What this is looking at some of special instructions. So the top one, the Cantrex, I have to turn sideways. Pediatric injections should not be, shoot, I got it. Pediatric injections should not be physically, so let's say, I can't, with other antibacterial agents. Is somebody gonna help me because, oh, mixed, thank you. I was having trouble with that. It looked like MB. Anyway, thank you, Wendy. Said, so should not be physically mixed with another antibacterial agent. So they may be able to take them at the same time, but don't mix them in the same syringe and keep them physically separate. So some special instructions, this one where you have to store, protect from light. Nitroglycerin is another one of those that we have, the injectable we have to protect from light. So this next one, recommended storage in dry form. Let's see, store below 86 degrees. Sterile solution should be kept. So special instructions about storage or about administration. This one just is showing the different names of the manufacturers. So Bedford, Acromax. I know I'm scrolling through these kind of quickly now, but I think this part is easier for you all to see and you're aware of. Expiration dates. Now that's one thing that we need to make sure of with our medications, is that we are checking expiration dates on the packaging. Yeah, expiration date 2012. I have been using these for a few years. Lot numbers or control numbers. Okay, so this is an important piece for this control number on the Novolin. Lot numbers, particularly with vaccines, we want to make sure that we record lot numbers. And one of the reasons is because if there's an issue with that medication, and it's not every medication, but there are specific medications, but every vaccine that we record lot numbers on, because if there is an issue with that particular lot, then we can backtrack and notify the people who have taken that vaccine. So lot number, and it's manufacturing information. It's like, what batch did it come from? Or the control number, who checked off on that medication. We have our national drug barcode, our NDC. So that is that number that I mentioned that is assigned by the federal government. And as this little blurb on the left said, it's just like a social security number, very specific for the medication. So NDC, that tracking number. Unit or single dose labels. Oh, just want to show that this label shows that is a single dose vial. We'll use it one time and toss it. If for whatever reason, let's say we only needed to use 0.1 milligrams, we get rid of the rest. We don't save it. So single dose, single use. Is there not a multi-dose? Come on, scroll. It's not scrolling with me. Maybe it's saying it's time. I know you all are probably saying it's time. Some combination drugs. So just to show you, so Percocet is the example that they have here. It is a combination of oxycodone, which is a narcotic, and acetaminophen, which is Tylenol. So the dosage below it, the 5 milligrams / 325, that means there's 5 milligrams of oxycodone and 325 milligrams of acetaminophen or Tylenol. Lortab. So Lortab is another narcotic. This is Lortab 500. That means Lortab, this is hydrocodone. So Lortab is the brand name. Hydrocodone is the generic name. So it's hydrocodone 5 milligrams and acetaminophen or Tylenol 500 milligrams. So combinations, and we need to look at these because these medications, both the Percocet and the Lortab, or the hydrocodone and the oxycodone, come in different formulations. So it might be a 7.5 and 500, or a 10 milligram in 500. So again, making sure that we get the correct concentration for what was ordered for our patient. And then some examples of that ratio. So real quick, these are not dosages. So epinephrine, so the 1 to 1,000, so that concentration, oops, that means it says oh, I thought it had it on there. So this is, it gives the information there. Says 1 to 1,000 contains 1 gram of pure drug in 1,000 milliliters of solution. So 1 gram. So 1,000 milligrams in 1,000 milliliters, or 1 milligram per ml. So that's a reduction. But when we're talking about concentration, so the example of heparin that I gave you, so 1 to 1,000 is 1 gram in 1,000 milliliters. So like in the case of the babies, where they gave 1 to 100, means that there was 1 gram of pure drug in 100 milliliters. So it's basically, I don't have full examples, but maybe meaning we wanted a concentration, I don't have them here, we wanted a concentration that had very little drug in a lot of liquid, but instead these babies got a lot of drug in just a little. So when they pulled up that half of milliliter, what they would normally give was a half a milliliter, or something that was like 100 times stronger. So the concentration, 1 to 1,000, 1 to 100, 1 to 10,000. Make sure that we're using the correct. This one's lidocaine 2% for injection. There are different formulations of lidocaine for anesthesia and other formulations, but we want to make sure that we're using that correct dosage. Okay, so I think that, yes, these are just some practice problems at the end, or more examples, but I will stop that. And oh
Will you
boy.
send us this whole thing, or is it already on Populi?
Wait 1 second. Okay, I'm sorry, Emma, what were you asking?
Is that on Populi?
No, that was what Wendy had asked me about. I said, I wasn't sure, but I have a note to I'll upload this.
Okay.
And if it looks a little jabby, I'll be honest, it came from a previous textbook, which I don't know if you all can see all of my pharmacology and dosage calculation books I've got stacked up over here. Some are newer, but some dosage calculations, they don't change. So I've used those through the years. So if some of those were scanned from another book, I will be quite honest with you, but I'll get those uploaded. So any questions?
Yeah,
So
I have one just like really
Sure.
quick. Sorry.
No.
So when we were going through, you said the macrolides and the aminoglycosides, they're easy to like distinguish because one, they have different spelling, but like whenever I look back over the slides, they both contained like the spelling with myosin with a Y and an I. So how do we tell the difference?
But most of them with the aminoglycosides are the I, and then and remember with the erythromycins, that's always the Y. But I was going to go to your. So the macrolides, those are always, that's going to be all, really except the fuloxamide, but just the erythromycins with the Y.
Okay, yeah, the last one was why I was confused because it.
Yeah, that's not a common one. Just focus on the erythromycins. So yeah, while these prefixes and suffixes are great, they're not always perfect. So But that would be the kind of the way to think of it with the macrolides. Think of the erythromycins with the Y, and with the glucocorticoids with the I. Did I say that correctly? I always wonder when I'm.
Yeah.
Yeah, make sure.
So then, but on that slide, it has them with the I too. So like gentamicin sulfate on the aminoglycosides. Or no, I'm sorry, neomycin sulfate and the tobramycin and the vancomycin on aminoglycosides.
Right, and I don't know, Emma, if it helps, it's just think of erythromycin being with the macrolides and not anything else. So any other of the asins, throw in with the glucocorticoids. Make sure I said, yeah. Like I said, it's not a perfect system with the suffixes. And I will tell you, if you're ever asked about the macrolides, it's always going to be about erythromycin. They don't throw in an additional with that. And the majority, and I will tell you that the focus with the aminoglycosides tends to be gentamicin, tobramycin, a little bit, and vanc. And remember, vancomycin, even though it is not truly an aminoglycoside, it's a miscellaneous that gets thrown in with those. So,
Okay, thank you.
but I know it can be confusing. That's when you find that perfect system, you go, okay, there's that outlier. Make it go away. I wanted to follow the rules.
Yeah, it was like super like confusing because I kept looking over and I was like, okay, I thought I had it down, but like I'm mixing them up.
You know, and I will tell you also part of what I will do, unless it says, penicillin or something that's really obvious, as we're trying to learn these, I will try to put in as a question, gentamicin, a cardiac glycoside, is, ABCD. So I try to give that information as we're learning it, because also you will find as you go through your med surgery and UR 120, and as you're learning about some of these conditions, these medications, they'll start to tie together and it'll start to form a better knowledge base, because right now it's kind of that memorization piece to it. So we're going to, adding that med surg piece to it will, again, help tie that, help to understand these a little better and get those solidified a little bit more in that knowledge base. So I wouldn't just put on there, I'm gonna pull out now I'm not gonna probably find one, pull out a drug. I wouldn't just say, of course I can't find one at all. Maxapine. I would say if your patient is on Maxapine, you need to be aware of what possible adverse reactions. That, by the way, happens to be a 4th generation cephalosporin, which I did not know that it was a 4th generation. But so it would say your patient is on, first of all, that was a name brand, cefepime, in parentheses, Maxapine, a cephalosporin, and is exhibiting signs of ABCD. So I try to give you more information because, again, you're still trying to learn this. Yeah, and there's so much information in pharmacology that I'm trying to help take those building blocks and build on that knowledge each time, instead of here's all of your anti-infectives. Learn everything you can possibly know about all of these anti-infectives, all of their drug classes, and everything goes along with it. That's overwhelming. That is absolutely overwhelming. So again, trying to help focus, and part of it is trying to go back and what I have heard from students and what helps them, as also what helped me when I was a student. I tried to study absolutely everything, and I think I cried after my first pharmacology test because I was trying to learn absolutely everything about every drug and list all these drugs, and I couldn't do it. I was overwhelmed. It just wasn't possible. So get that focus, get that building blocks, and we'll go from there. But as we go along, please, and Emma, I appreciate you asking questions, but if there are other questions or if there's something, a different way I can explain things, please let me know. As we go into some of these body systems, I will do a little brief anatomy review, and I mean brief, just to kind of help bring that information or that body system and its functionality into the forefront of our minds, so then we can better connect how those medications and those classifications work and how they affect. But we'll get there. This first one's tough. It's tough just because it's all new information. It's a and a different way of taking it. We're taking that, we're going to memorize it, but now we got to start applying things. So again, we talked about red man syndrome. There might be a question, your patient is on vancomycin, which is, a cardiac glycoside, an aminoglycoside, and is complaining of a fever, chills, headache. What is your first response? Well, we now know that that is a known reaction. We're going to treat the symptoms and continue with the infusion. So it's taking that, not just your patient's complaining of fever, chills. What do you think it is? Oh, it's red man syndrome. No, it's red man syndrome. Now what am I going to do about it? But you're getting there. We're going to take these we'll take baby steps and we'll get there. But please let me know if there's anything else I can do to help you all in the way of explaining things or support materials or anything, because that's what I want to do, is help you all to learn and understand this. And now I keep talking, and now it's after 4 o'clock.
I don't know if it would even be possible, but like, is there any way that we can get like a worksheet of like what is going to be asked of us on our quiz? Like kind of like not the exact questions, but like, I don't know, like stuff to maybe like prepare for the format, I guess.
Well, I will tell you, the format is, it's pretty much like any other nursing. Now, I don't do, I'm not a study guide person. I'll do a review, but I don't do study guides. Let's see, we've got a quiz coming up. Is it next week? So, and what I did with the first group and what I'll do with you all is it will be a quiz on Populi. And that first quiz, it will be worth 20 points. Is it 20 points? Anyway, but it's going to be one of those, if you attempt it, regardless of the grade you get on it, you will get the full points. And to kind of give you an introduction to how questions might be worded in the formatting. Okay. So the quizzes will be over Chapter 12 anti-infectives and then anti-inflammatories that we'll go over on Thursday. But again, it's I say a practice quiz, a quiz. So it's to get used to the format, to kind of get used to that timed. I'm on Populi taking an electronic quiz in a class of which, is brand new. And so I hope that works out, is kind of a trade-off for you all, or helpful for you all. So again, it'll be set up just like it was a graded quiz. It just, at the end, regardless of the grade on it, if you've attempted, and don't go in there and just click, obviously, but if you've attempted it, you do get full credit for it. But again, to kind of do that introduction into Melody's pharmacology questions. So I think that is next Tuesday. So we'll do that at the beginning of class before we, and then we'll Zoom. But I think if it's okay with everybody, on Thursday, I think we'll start with some dosage calculations. Get a little introduction to that. It's too easy for me to keep going at the end to with the information on from the PowerPoints and the different drug classifications. I'm afraid that I keep pushing time, and here I keep talking again. Now we're 10 after. So Thursday, we will start with some dosage calculations. If there are any particular ones that you would like me to focus on, or particular problems that come from that dosage calculation book, kind of flip through there. We can work through there. I'll try to pull up some and send you all maybe some worksheets and things that I have so that you can work on those, or we can work on those together, and you can have those before we get to class. And I will add that on to my to-do list, dose calc worksheets. And then we will, after doing some dosage calculation practice, we will roll into chapter 13, our anti-inflammatories. Sound like a plan?
Yes.
Okay.
I do like finding doors.
If you all don't have any questions, then have a great day, and thanks for hanging with me late today.
Bye, Melody.
Bye-bye.